100 years ago, 4 scientists walked from their small lab at the University of Toronto into the diabetes patient area at the Toronto General Hospital to test the first shot of their newly discovered and life-saving treatment, insulin. The collaborative efforts of Sir Frederick Banting, Charles Best, J.J.R. MacLeod, and James Collip anchored a road of century-long growth, marking Canada as a leader in groundbreaking health tech discovery. Hi there, I'm Neil Fraser, President of Medtronic Canada, and this is The Next 100, a new podcast that celebrates the first 100 years of insulin with conversations about the future of healthcare discovery and innovation in Canada. I feel so privileged to be here with a very accomplished Dr. Robert Reid. He is the inaugural Hazel McCallion Research Chair in Learning Health Systems and also the Chief Scientist at the Institute for Better Health, as well as being Senior Vice President, all at the Trillium Health Partners here in Mississauga. Dr. Reid is also a professor at the University of Toronto and at McMaster University. Dr. Reid is currently providing leading expertise on the Ontario health teams, and there'll be lots more on that in a minute. Dr. Reid has dedicated his life to improving the health of others, while he himself lives with type 1 diabetes. It's a pleasure to have him join us today for our first episode of the Next 100 podcasts. Welcome, Robert. It's really a pleasure to have you here.
Well, it's so wonderful to be here on your inaugural podcast, Neil, and to discuss diabetes and the future of where we're going. Just take a moment to reflect on 100 years of insulin and the University of Toronto and the accomplishments of Canada. There's not a moment in Canadian scientific history that is probably more important and more relevant to people across the world than the discovery of insulin. And me and many of my other the diabetic patients across the world owe a tremendous gratitude to Canadians and those researchers 100 years ago. And, diabetes has advanced so much in the last 30 years that I've had diabetes. We saw the introduction of new insulins. We saw the new introduction of home glucose monitoring, pump technology, preventive medications, smart technology now, and novel ways to now treat complications of diabetes that we had never even thought was possible years ago. And so, the advances in science have made the lives of diabetics, and starting in Canada, so much better. And it's just terrific to kind of celebrate the history of research in diabetes, but also the next 100 years and what the Canadian footprint will be going forward. So thank you for inviting me to the podcast.
That was just fascinating, all your thoughts about that. We're going to dive into that in a minute, but I noticed that at University of Washington, Kaiser, that you developed something called a patient-centered medical home. My question is, was this pertinent to diabetes care? Like, did you develop specific pathways for diabetic patients? And how did that work as part of a patient-centered medical home?
Yeah, that's a great question, and it kind of links onto my work and the relevance for people with diabetes. When I was early in my career, we spent a lot of time thinking about how to deliver diabetes care consistently and engaging patients in their own care. How do you do that? And through colleagues at the University of Washington and at Group Health Cooperative, developed what was the earlier iterations of what was called the chronic care model, initially based in diabetes. And it was all about how to organize and deliver care proactively to patients and members so that we could avoid complications in the long term. Over time, that morphed and was a pattern around how we should organize chronic illness care beyond diabetes in general. So not only diabetes, but mental health, care for chronic renal disease, and so forth. and became a layer on which we redeveloped primary care, because primary care at its essence needs to care for people longitudinally, be patient-centered in their approach, and really equip them in terms of self-management. And that was the birth of the patient-centered medical home, which was a new way of organizing delivery of healthcare using new technologies like video messages and so forth to actually reach populations of patients. And that early work, continues to be very relevant about how we reinvent healthcare to make sure that we're drawing everybody in that has diabetes, chronic illness, or any other type of concern, and not let them fall through the cracks.
And do you see the work that you did at Washington as analogous to the work that you're now doing with this new Ontario Health Team initiative that you're leading or informing?
Absolutely. The Ontario Health Team at its heart is about actually redeveloping primary care in many respects, with the patient-centered medical home as the baseline. And building on that, it's also then how to bring in and support hospitals and home care, specialty care, so that care is organized across the full spectrum of patients rather than piecemeal in its approach. And so it really is about developing local systems of care, and that's what Ontario Health Teams is all about.
And one thing that has confused me about Ontario Health Teams is just that, and I'll just use the term aggregator if it's okay. I look at the Ontario Health Team as a horizontal or geographic aggregator of patients of all kinds versus a vertical aggregator, which would be something like you referred to, focusing on mental health or diabetes. So how do the needs, the vertical needs of high-end specialty care intersect with the horizontal needs of a geographical population?
Ontario Health Teams is about integrated care, absolutely integrated care, vertically integrated care from primary care and home-related services through to specialty care, hospital, and high-end care, inclusive of mental health, long-term care, and the spectrum of care needs that people have. But holding a group of providers like this actually responsible for caring for a geographic or a group of people. So it's population-based. So, here in Mississauga, our Ontario Health Team now is responsible for caring for people that live in Mississauga across that spectrum. And that's what Ontario Health Teams is supposed to do. But what's really important is that it's all based in primary care. Primary care is the heart, the living, and research across the world has told us that health systems don't work very well unless they have a vibrant, well-equipped, well-prepared primary care workforce that is integrated in the rest of the system.
And so if you're a patient that's let's say rostered in a primary care network or a medical home, and let's say that you present with type 1 diabetes, so what's the role of the primary care person to make sure that you get the appropriate care in a very demanding area such as type 1 diabetes?
Yeah, you're absolutely right. The needs of the patients with diabetes occur across the spectrum. Many patients with diabetes have depression care and depression and a whole host of other issues that we need to co-manage. Primary care's role is to make sure that we provide a person-centered approach and fundamentally work on integrating that care across the spectrum. But they can't do it alone. We need a system that actually that allows that to happen so that we're not relying on individual family doctors to make all those connections, navigate all those referral networks, navigate wait lists and all those sort of things. Those become system properties that need to be managed. The primary care helps navigate with patients through it, but the system picks up and actually integrates care.
So just as I'm learning from our conversation, how does the system learn, and what is what is a learning health system in your mind, and how does it adapt?
It's a great question. And, in Canada, we've done a lot. There's been a lot of experiments in health service delivery, and often they're done in pilot phases or in isolated circumstances. And, they disappear once the project is done. And the learnings are not coherently spread across settings or actually over time. And so the learning health system is really the idea about how we actually insert research right into healthcare operations, so that we learn how to design research that's patient-centered. We learn how to adapt it for the localities that we're working in, because everybody has different set of resources in Northern Ontario versus in downtown Toronto. We need to adapt it for different settings. And then we need to do small tests of change. We need to try things. If they don't work, we need to adjust them. And we learn as we go. And that's at the essence what a learning health system is. It's really taking research expertise fundamentally into a learning system like a hospital or an OHT or a primary care practice. And in many respects, it's just extending the ideas behind quality improvement now to using research relevant tools, artificial intelligence, all types of things that we can now bring to bear to make systems work better.
That's very exciting. So just getting back to our topic of the next 100 years, what do you think the pathway looks like in the next 100 years, and what do you think will be the big innovations that Canadian physicians and others need to aim for? And I'll give you three to choose from. It may be the combination, but is it going to be a biological innovation, like a new molecule, like mRNA has been in COVID? Is it going to be a technological innovation, such as you mentioned, continuous blood sugar measurement or continuous infusion of insulin? Or is it going to be information technology and care pathway design?
I think it's all going to be all three, to tell you the truth, and it's going to need to be all three. So, I hope there's new discoveries, and Canadians continue to take the lead in this. And my colleagues in the basic sciences at places like University of Toronto are just doing stellar work and continue to do. And I hope that their science really delivers new innovations and new things in the biomedical sphere that can lead to cures and things that we have not contemplated to date. I'm betting that we're going to continue on this path like we have been. The second is that IT and innovations in information technology, we're only at the cusp of this at the moment, where we're using information in novel ways to make sure that people get the technologies when they need it, okay? So that they are not required to actually make a visit, but we can actually go to them rather than actually them having to come in. So I think new technologies are really going to change care delivery. The second is, I think, the new information sciences will coming out around predictive modeling so that we can design things and interventions for people in advance rather than waiting for things to actually happen. So we're really using the science of new information technology to do that. And then I think the third is, let's hope that we have new technologies and we have new drugs, devices, and discoveries. But they'll only come to fruition if we get them to the people at the time that they need them across the population. So we need advances in care delivery and new models of care, new ways to deliver care, and particularly new ways to engage people in their own care. I am in control of that diabetes. I make the care decisions every minute of my day. And so we really need to equip patients across the spectrum and in terms of the self-management for their own diabetes, because that is at the true heart of what diabetes actually is all about.
And one last question I've been aching to ask you. I read this recent paper by Drummond and Sinclair, where they talked about the need to move from the biomedical model. In other words, you're sick or you have a problem, we have to treat you, to a more expansive view of health that would include the social determinants of health. How does that come into play?
That's the next advance as well, is that, we have been thinking about learning healthcare systems, and we need to think more broadly about learning health systems. There are many things that impact people's health. Only one of them is medical care, education, income, housing, those types of things. We have systems around that, but we largely don't integrate across the spectrum of schools, of housing departments, of how to finance care to improve health. That's where our world really needs to go, because that's where we'll probably have the biggest impact and the most equitable impact, because equity is an enormous challenge for us. The technological advancements that we talked about are at the moment very hit and miss in their application. And it's uneven in terms of who gets it and who benefits. And many people who are disadvantaged for a whole host of reasons don't benefit in the way that the way that they could. So we really need to tailor our approaches across the socioeconomic spectrum in better ways to meet those challenges. That's where we need to go.
Excellent. Well, this has been fascinating, and thank you so much for all of your incredibly well thought through answers. And we'll wrap it up here. So thank you.
Thank you, and thanks so much. And I can't wait for this next 100 years.